And a central part of this reform is having an efficient pricing structure to drive the best possible way of running hospitals. Fran, what this reform also promises is national standards, national clinical standards, which would set the amount of time that someone could wait, that, clinically they can wait that amount of time if a local hospital network was not in a position to end up meeting their need in the clinically recommended time. Then the door is open to purchasing capacity from private hospitals, for example, or making arrangements with nearby local hospitals. But this reform is not about closing hospitals. Closing hospitals, opening hospitals, responding to population growth, population planning would be in the province of state governments. But inherent in this reform, and this is a really important point, is the federal government stepping up to the plate on capital needs for hospitals. When we talk about a 60% funding share, we're also talking about a 60% share including the capital, and that's been a huge strain on state governments, and over time obviously that strain has showed.
And just before we go briefly, that 60% share, that's completely uncapped, isn't it?
Well, the essence of this reform is you have an efficient price, you have a system that meets demand, obviously, demand for appropriate procedures. You're not going to be operating on perfectly healthy people for nothing, but if people need procedures, then there will be an efficient price. If that procedure happens, then obviously it will be paid for. So there aren't artificial caps. You don't say, we'll only do X number of hip replacements when a larger number of people in the community need the hip replacements. You'll pay for the hip replacements that are needed at the efficient price.